Evening, everyone. At the outset, I would like to thank the organizers, especially Dr. Shubham, Dr. Charu, Dr. Harit, and all the organizers for giving me this opportunity and rather very interesting topic here, though I have modified a subject little bit. Uh, so the relevance of this topic, just the relevance of this topic stems from the rapid and very gratifying improvements in survival observed in this patient population. This allows more time for brain metastasis to develop and for patients to face the consequences of radiotherapy. So while in the recent past, the appearance of brain metastasis prompted reflex whole brain RT, we move towards stereotactic radiosurgery. So there is now irrefutable evidence that mutant non-small cell lung cancer have a higher rate of brain metastasis. And for a while, we were comfortable with sequencing stereotactic radiosurgery followed by TKI. But with the emergence of CNS penetrating TKIs, the optimal management is again in a state of evolution. And with the emergence of immunotherapy, I anticipate that it is going to get a lot more complex. Though I will be addressing specifically a mutant non-small cell lung cancer, because of paucity of time, I will not be covering the immunotherapy part also. So, but before we delve into this topic, let's take a glimpse at the spectrum of survival in this group of patients. And it is astounding to see that, that some patients can survive up to 4 years after being diagnosed with brain metastasis, when just 2 decades ago, we expected only half a year of survival. Maybe some people might disagree, but this progress has been the result of concerted efforts made by both medical and radiation oncologists. So the journey from whole brain radiotherapy to SRS is a lecture on its own. But keeping in mind the multidisciplinary members of this meeting, I will stick to the key highlights. While it is currently fashionable to criticize whole brain radiation for its shortcomings, it has served us well in the past. So before the turn of the millennium, whole brain radiation was all we had, and it offered something to the patients and their families. With the development of SRS, early results suggested that it had an incredible local control rate with several advantages over whole brain RT, but had a higher intracranial failure rate, which is why investigators focused on adding whole brain radiation to SRS. But a meta-analysis by Dr. Sahgal, in which almost 60% of the patient had lung primary, this meta-analysis cemented the place of SRS in the management of 1 to 3 brain metastasis. And with increasing utilization of SRS and declining whole brain RT trends, survival in large database analysis, it doubled. And the Quartz trial suggested a diminished role of whole brain radiotherapy, though this trial has its own flaws. So an alternative whole brain technique was developed, which preserved neurocognition by sparing the hippocampus, while simultaneously delivering a higher dose to a macroscopic lesion. And I hope this topic of hippocampal avoidance will be dealt by Sayan in his next talk. So I'm just not going into detail of this thing. But interestingly, you will notice here that this timeline ends somewhere around 2017. And its significance I will reveal in my next few slides. With that background, we turn our attention to a mutant non-small cell lung cancer. I was overjoyed to see that that sequentially delivering tyrosine kinase inhibitors in mutant NSCLC after SRS was further improving outcomes for our patients. And across diverse population, you can see in all these trials and agents, we were seeing near doubling of survival and were phasing out whole brain radiation from our algorithms. We also understood that concurrent TKI with RT is not a good idea due to higher risk of radionecrosis, as many of these series actually revealed this thing. All was going well till around 2017. Medical and radiation oncology were finally coming together, but a tsunami was coming. And this tsunami of data on next generation TKIs. Their impressive extracranial activity was matched with the data suggested that they were effective in preventing intracranial progression in patients with asymptomatic brain metastasis. While reviewing the literature of all these trials, I contemplated describing every trial in some detail, detailing individual relative risk and hazard ratio for each agent, and trying to draw some meaningful conclusion for this audience to take home. And instead, questions came to my mind. Were these trials powered adequately to answer the question of sequencing, or were they byproducts of exploratory unplanned subgroup analysis? Is there a reason why only a minority of them report objective local control rates, and why details of delivered RT were unreported, though they were allowed? And finally, all these trials did not compare survival or progression-free survival head-to-head with SRS. So if these trials were not designed to answer the question of sequencing, I would rather consider their conclusion of postponing SRS till progression simply hypothesis generating, not practice changing, though many will not agree. And we can argue this debate till results of some of these ongoing trials in Australia, Canada, and America are published. And perhaps next year, I might be talking about how I was misguided in my current opinion. But till that time comes, let's look at this meta-analysis, which was specifically designed to study the sequencing of SRS and TKIs, published in Green Journal last year. There are many other meta-analyses, but I have included this one because this is a recent one. And also it included some of these next generation TKIs, CNS penetrant TKIs. So the population was predominantly EGFR mutant rather than ALK mutant, reflecting the real world distribution of these mutations. And sequential SRS and TKI improved progression-free survival by 5 months, missing the significance mark by just 0.01. The difference in overall survival, though, was not significant. So looking at this high quality multi-institutional data where the trend towards improvement in progression-free survival was there, I am compelled to predict that similar to the trials of SRS and whole brain RT, where appearance of new metastases were prevented by whole brain RT, resulting in improved intracranial progression-free survival, adding TKIs to SRS will also improve intracranial progression-free survival in mutant NSCLC. And essentially, TKI could replace whole brain RT in our algorithms. But the premise of this approach rests on the question, what is the limit of SRS? And this is the topic of my talk, the next part of my talk. And if you ask this question to head of the Japanese Lexel Gamma Knife Society, Dr. Yamamoto, and review his literature, there are no limits on the number of lesions which can be treated with SRS, as far as his opinion goes. The pivotal JLGK0901 study is revered in the radiation oncology community as the first of its kind, proving that patients with 2 to 4 brain metastases had equivalent survival to those with 5 to 10 brain metastases. And this came a full year before Seigel's meta-analysis, which made SRS the standard of care for limited brain metastases in America and Europe. And a full 5 year later, Hughes et al. Replicated the results of Dr. Yamamoto in an American multi-institutional analysis, suggesting that the survival of 2 to 4 and 5 to 15 metastases were equivalent. Pushing the envelope even further, Dr. Yamamoto in his next analysis proved that patients with 2 to 9 metastases enjoyed equivalent survival when compared to the range of metastases, which ranges from 10 to 63. So this was quite astounding. For brain metastases arising from non-small cell lung cancer, his group replicated the results of JLGK901 study in this particular group of non-small cell lung cancer. And interestingly, if you look here, when substratified by the time of treatment, these patients received after SRS, TKI or TKI followed by chemo, which was given on progression, it was statistically equivalent. Since these TKIs were first generation TKIs, consider the possibility of adding next generation TKIs to SRS, as I had shown you in my previous slides. So it is not implausible to assume that our current preference of radiotherapy technique based on numbers alone will evolve from hippocampal avoidance whole brain RT for more than 4 metastases to more than 10 metastases. And there is an emerging endorsement for this approach from the American Radiation Society, announced just 1 month back in their annual conference. And hopefully ongoing head-to-head trials comparing SRS with whole brain RT will answer this question in the future. But before we all head back to our clinic on Monday and start irradiating up to 10 metastases with radical intent. Let's, for a brief moment, also consider the limitations imposed by technology. Dr. Yamamoto's result arise from a long experience with working exclusively with gamma knife, a single-purpose delivery platform designed exclusively for intracranial treatments. And advances in technology like CyberKnife and linear accelerator-based SRS platforms have wider availability and applicability. And as our experience with these platforms increases, we will appreciate the inherent trade-offs associated with each technique. In the interest of time and to maintain the attention of our multidisciplinary audience, suffice to say that SRS planning and delivery is not an easy endeavor. From my own experience with delivering SRS for a single patient, I can safely say that it requires at least a full working day to create a high quality deliverable plan. But eventually, it is immensely gratifying to see the hard work pay off. In last 2 years, we have treated 127 brain metastases in 58 patients with up to maximum of 4 lesions per patient. We are in the midst of analyzing our results and we anticipate sharing them soon. So to conclude, we try to follow this algorithm. Specifically, if we focus on symptoms, asymptomatic TKI naive, where the visceral crisis or a visceral extracranial disease is not alarming, and the metastasis ranges between 1 to 4 brain metastasis, we try to convince our medical oncologist colleague, and specifically Dr. Ullas is there, you all can understand how difficult it is to convince him. So we have to convince them to go ahead with radiation first, followed by TKI. But if the lesions are more than 4, or if somehow not amenable for SRS, then probably we try to avoid whole brain radiation as far as possible. Well, things are not so simple as it seems to be, and you would comprehend it fully if you witness our multidisciplinary tumor board, as Dr. Darlang was mentioning earlier. So to add to this complexity, financial status of the patient also plays a major role in decision making. I think Dr. Kumar Prabhash will be talking about that also. Making decision difficult for both with regard to choices of TKIs and the technique of radiation. So finally, this topic is ever evolving and we will have to adapt to this rapidly changing landscape. It is so heartening to see that we are discussing the management of NSCLC with brain mets so that we have prolonged survival along with good quality of life, while 2 decades back, this same scenario was considered as lost battle. Hopefully, there is still a lot to come and future may unlock our limitations in treating and further improving outcome in these patients. Thank you.